Ra đời từ tháng 8 năm 2018, Quỹ đổi mới sáng tạo Vingroup VinIF đang dần khẳng định vị thế, vai trò người đồng hành uy tín, tin cậy cùng sự phát triển khoa học công nghệ của quốc gia. Với nguồn kinh phí hàng nghìn tỷ đồng, VinIF không ngừng kiến tạo những ảnh hưởng tích cực cho sự phát triển bền vững của đất nước trong suốt 5 năm qua. Cùng sự chung tay của hội đồng trên 300 nhà khoa học, chuyên gia uy tín trong và ngoài nước, Quỹ đã tài trợ trên 750 tỷ đồng cho gần 110 dự án khoa học công nghệ và văn hóa lịch sử, hơn 1.100 học bổng thạc sĩ, tiến sĩ và sau tiến sĩ, 6 đề án đào tạo thạc sĩ khoa học dữ liệu, trên 130 hội thảo, bài giảng đại chúng và hợp tác với trên 90 viện nghiên cứu, trường đại học hàng đầu cả nước.
5 năm trước, Quỹ VinIF được tập đoàn Vingroup thành lập trong bối cảnh nền khoa học công nghệ Việt Nam đang cần một bước ngoặt lớn về chất và lượng. Thì sự ra đời và hoạt động của Quỹ trong 5 năm vừa qua cũng đã tạo ra được dấu ấn trong việc hỗ trợ nghiên cứu khoa học tại Việt Nam. Trong 5 năm vừa qua, thì Quỹ VinIF đã tạo dựng được khá nhiều chương trình có tính thực tiễn cao đối với giới khoa học và giới sinh viên của các trường đại học. Cái phần thưởng lớn nhất cho chúng tôi là các chương trình này đã thu hút được sự tin tưởng từ các nhà khoa học, sinh viên các trường đại học, các viện nghiên cứu. Cao hơn nữa thì nó cũng tạo được sự theo dõi sát sao từ các nhà nghiên cứu hoạch định chính sách, và chúng tôi hy vọng đó sẽ là tiền đề để tạo ra những bước ngoặt lớn hơn trong cái việc hỗ trợ việc nghiên cứu khoa học tại Việt Nam.
Cho đến nay, VinIF đã mở 7 chương trình tài trợ thuộc 4 mảng chính. Về khoa học công nghệ, Quỹ đã tài trợ cho trên 100 dự án thuộc nhiều lĩnh vực khoa học công nghệ trọng yếu với tổng kinh phí lên tới 530 tỷ đồng.
Nền khoa học công nghệ Việt Nam đang đi rất là đúng hướng so với tất cả các nước quốc gia đang phát triển ở trên thế giới, quốc gia đã phát triển. Đó chính là có cái sự tham gia đồng hành của cái khối công nghiệp, của các doanh nghiệp vào cùng đồng hành với chính phủ trong cái việc là tạo thêm cái nguồn lực cho phát triển khoa học công nghệ.
Các dự án được tài trợ đều là những nghiên cứu xuất sắc, có tầm ảnh hưởng sâu rộng, tiềm năng ứng dụng lớn với phương pháp tiếp cận nổi bật và hiện đại, không chỉ tạo ra những sản phẩm nghiên cứu có giá trị tri thức và ứng dụng thực tiễn cho xã hội, mà còn thúc đẩy các hoạt động nghiên cứu mũi nhọn, xây dựng mạng lưới hợp tác trong nước và quốc tế. Song song với việc tài trợ các dự án khoa học công nghệ, nhiều chương trình tài trợ học bổng đã được VinIF triển khai cho các cấp thạc sĩ, tiến sĩ và sau tiến sĩ. Bên cạnh các chương trình học bổng, năm 2020, Quỹ VinIF đã triển khai chương trình tài trợ và hợp tác đào tạo thạc sĩ khoa học dữ liệu. Sau 3 năm, Quỹ VinIF đã ký kết 6 đề án đào tạo thạc sĩ liên kết với viện nghiên cứu, trường đại học đầu ngành ở Việt Nam với kinh phí cho mỗi đề án là 2 tỷ đồng mỗi năm trong thời gian 3 năm. Với sự thúc đẩy của VinIF thông qua chương trình này, hai ngành khoa học dữ liệu và trí tuệ nhân tạo đã khẳng định là hướng đi đúng đắn trong việc xây dựng nguồn nhân lực khoa học công nghệ của Việt Nam, trở thành hai ngành mới trong danh mục đào tạo trình độ đại học, thạc sĩ, tiến sĩ của Bộ Giáo dục và Đào tạo.
Chúng tôi cũng mong muốn là tạo ra là một cầu nối, ít nhất sau này cũng sẽ đưa được rất nhiều bạn trẻ đến với các trung tâm đào tạo và môi trường làm việc quốc tế. Thì những cái đó là mục tiêu của chúng tôi đề ra. Và quỹ của chúng ta là một cánh tay có thể nói rằng giúp chúng tôi thực hiện được những cái nhiệm vụ này. Và trong bài toán khi chúng tôi xây dựng quỹ học bổng của Đại học Gia Hà Nội thì cũng hoàn toàn là có một sự hợp tác và phối kết hợp sau này với quỹ rất là tốt.
Thông qua các chương trình, VinIF đã thúc đẩy và xây dựng văn hóa nghiên cứu sáng tạo theo đúng chuẩn mực của quốc tế, kết nối những người đã nhận học bổng và xây dựng mạng lưới các nhà khoa học trẻ với 1.000 thành viên của câu lạc bộ VinIF Alumni với tinh thần cống hiến, sáng tạo, hội nhập. Ngay từ những ngày đầu thành lập, VinIF đã phối hợp cùng các cơ quan, tổ chức, đồng tổ chức và tài trợ cho các bài giảng đại chúng và hội thảo quốc tế uy tín. Thông qua sự phối hợp chặt chẽ cùng việc tổ chức chuyên nghiệp, trên 130 hội thảo, sự kiện lớn và bài giảng đã được diễn ra với hàng trăm diễn giả uy tín, trong đó có các giáo sư đầu ngành, các giáo sư đạt giải Nobel, Turing, thu hút trên 1 triệu lượt xem và tiếp cận, có sức lan tỏa tới toàn xã hội. Bên cạnh khoa học công nghệ, chương trình lưu giữ các giá trị văn hóa lịch sử cũng là một dấu ấn đặc sắc của VinIF đối với giới nghiên cứu, văn nghệ sĩ thực hành văn hóa, nghệ thuật, lịch sử nói riêng và giới khoa học xã hội nói chung. Quỹ đã tài trợ cho hàng chục dự án cùng nhiều sự kiện có ý nghĩa quan trọng thuộc nhiều lĩnh vực như dân tộc học, di sản văn hóa, âm nhạc, mang tầm vóc quốc gia.
Để thực hiện được sứ mệnh của mình, chúng tôi luôn theo đuổi những giá trị cốt lõi đó là tinh thần cống hiến với sự tài trợ hoàn toàn phi lợi nhuận, đó là sự công bằng thực chất để cho các nhà khoa học có thể làm việc người thực, việc thực, có sự văn minh để các bạn trẻ sẽ có tinh thần cống hiến vào khoa học, và đặc biệt là chúng tôi luôn mang tính sáng tạo. Những chương trình của chúng tôi sẽ luôn cập nhật và để phù hợp với cả đòi hỏi của đất nước.
Từ những thành quả đã đạt được, VinIF sẽ tiếp tục sáng tạo để phát triển, góp phần nâng bước cho tri thức, tạo lập môi trường nghiên cứu tốt hơn, từng bước hiện thực hóa sứ mệnh, cống hiến vì một Việt Nam bền vững.
Okay. Good afternoon, good morning, good evening, depending on which part of the planet you are. It's great being here with you. I see we are 13 participants joined so far, 12 including us. And in the next 30 minutes or so, I'll try to go through a concept that it's known as population, as public health pharmacogenomics, in the sense that this refers to how pharmacogenomics could interact with public health. I am a professor at the University of Patras, and also I'm very pleased to be the advisor for Big Data Foundation. So if we want to try to make some kind of a metaphor of how would an ancient, how we can get genomic research into genomic medicine from the research of the clinical implementation, then we could use an ancient Greek temple to make this this metaphor. So let's suppose that you have a lot of pharmacogenomic research that is considered to be the foundations of a temple, and we need to move this to the roof, which is the implementation, the clinical implementation of genomic medicine. For that, we need pillars, and one of the pillar is genome informatics. The other one is ethics in genetics, which is very important to consider. It's public health pharmacogenomics and public health genomics, so the aspects of genomics that touch upon public health issues, raising the general public awareness, educate healthcare professionals, last but not least, performing economic evaluation of genome-guided therapeutics. So this is what public health pharmacogenomics is about. The first part is how we bridge the gap between the bench and the bedside. So you have two types of scientists. You have the researchers, which is like this guy, that he communicates the result of a genetic analysis. And then you have the clinician. And the clinician has to basically understand what the lab scientist says. So they have to communicate this in a very clearly understandable manner. Otherwise, he wouldn't be able to understand what the lab scientist tells him or her. And for that, we need to have translational tools. We need to have tools that translate genomic information into a clinically meaningful format. So basically, translate genetics into Vietnamese, English, whatever, Arabic. So we have created a tool that does exactly this. So there is a kind of an interface that can be accessed by medical professionals, research laboratories, and visitors. And this is basically different types of individuals that they have different rights to access this particular portal, this tool. So the patient could be able to search for the information, to receive personalized pharmacogenomics recommendation, and to access personal information. You may have the data submitter, which can be a researcher, and in this case, he could submit new alleles, new variants, update existing one based on his own contribution, and search for pharmacogenomic information. Then you will have the medical professional that he will not only be able to search for pharmacogenomic information, but also to access the patient data upon authorization from the patient. And last but not least, we'll have the administrator of the database that would be able to install, upgrade, and maintain the server, ensure that the system is securely run, to control and monitor the user access, and last but not least, to back up and restore the data when needed. And to have this access, this can be done using a card, a plastic card that would grant access to the patient and to the medical professional. What I used to say in the past is like having being in a nuclear submarine where you need 2 keys to launch the missiles. So this is what makes the whole thing ultimately secure. So such a system would get recommendations from different sources like CPIC, Dutch Pharmacogenomics Working Group, the literature, PharmGKB, other NCBI databases, Affymetrics, like one of the sources of information, and those are extracted in different file formats. Such format could be a CMV file, Excel file, Word file, and so on. And these are entered into the database warehouse, which has all the information required, and this will be bidirectionally communicating with the individual's electronic healthcare record. And at this particular backstage, you could communicate this with the front office, which is basically the screen. Okay. Okay. Hope it's clear so far. Okay. Sorry for the interruption. I was trying to locate my moving forward. So, how this translational tool will work? Let's say that we have a patient that have this particular genetic profile, and simply the genetic profile means nothing to the clinician, because having a variant in specific genes doesn't mean anything. But if you have a translational algorithm, then you can have the allele matched to a specific metabolizer status. So this particular variant could correspond to a poor metabolizer, and this variant could correspond to intermediate metabolizer, and so on. The metabolizer status may mean something for the clinician, but still is not enough. So a second translational algorithm could allow him to retrieve the pharmacogenomic information and get him the recommendations in his own language. So this particular tool will fetch the recommendation and will match it unambiguously with a genetic profile of the patient. So it's like translating genetics into Vietnamese. Okay, so that's why these tools are called translational. And that's what a report would look like. This would be the phenotype, if it is an extensive metabolizer, intermediate, or a poor metabolizer. And that's what a report would look like, because you could click on those particular tabs where you can get the clinical annotation, which means that patients with this genotype and psychiatric disease, when are treated with this particular drug, which is olanzapine, may have decreased response to olanzapine based on the decreased main dose body weight average. Okay. Okay. So This tool has been already been updated. It has an ML component. It has been patented, and now there's a commercial entity that is formed in the United States that is based on that particular tool. Yeah. Okay. So one other aspect of public health pharmacogenomics is resources that will bring you the information available from various sources in your table, in your platform. And such a tool is this database, which triangulates between drug, gene, and the genetic variant. So the way it is being done, this is basically the creation of the database that was developed under the auspices of the Genomic Medicine Alliance. And this is what the database looks like. This is a gene, the drug, and that's the indication here that refers to toxicity. Because sometimes the regulatory bodies do not refer to this information when they provide this in their own resources. And this details is what you have here, and that's the bottom line from the recommendation provided, which says, for example, here that you need a dramatic dose reduction between 30 and 70% of the initial dose to avoid lethal myelotoxicity. So that's what type of information is being communicated from the regulators, which is in this case the EMA and the FDA, to provide this to the user of this database. And that's how the overall screen of the database looks like. It looks like nice little boxes that resemble to the boxes I've showed you here. Okay, so that's a very nice collection, and the dynamic reallocation of the search results once you decide which drug to focus on. And as you can see here, the majority of the genes and the variants belong to the CYP2D6 allele, which is the commonest one among the variants that we deal with in pharmacogenomics.
So what color mean? The previous one, what color mean? What does the color mean?
The color is nothing. The color is chosen arbitrarily from the system. The important thing is what the information you get. So the query here is DPYD variants. So this is retrieved by providing *2, *3A, *3C. Okay, and there the query is which variants are related to toxicity or lack of efficacy. So the first group are the variants that are related to toxicity, and the variant next to it, the single one, is the one that refers to the lack of efficacy. And as you can see here, we're talking about metronidazole. Okay. Now, we come now to a different type of analysis, because to implement pharmacogenomics, we certainly need to consider how the stakeholders, the various stakeholders, think about pharmacogenomics. And this is quite crucial to expedite the adoption of genomics into mainstream medical interventions. So this was done in 3 steps. The first step was to define the policy, the content, the goals, and the mechanisms to implement genomic medicine. Then we need to have the key players and analyze their positions, their opinions, and the power of intervention, and the opportunities and the obstacles to affect the feasibility of developing a specific policy. So to do so, we implemented a computerized version of a tool that is used mostly in US politics, and they use it to try to identify how people think before and after lectures given by candidates for national or state elections. And this is what the situation in Greece looks like. In white, you see, white means low power of intervention, gray means medium power, and black means very strong power of intervention. And dark green means highly supportive, and dark red means highly opposed. And as you can see here, the majority of the stakeholders have a very highly supportive or supportive attitude towards personalized medicine. But as you can see here, you see two important aspects in the system. First of all, you have a non-mobilized stakeholder, which is the National Medicines Organization and the press. And that's very disappointing because you would expect that the National Medicines Organization to be highly motivated, but apparently it's not the case. But most worrying stuff is that the Ministry of Health and the Public Insurance Fund are very opposed to implementing pharmacogenomic and genomic medicine. And the reason for that is most likely because this study was performed in 2013. And 2013 was the peak of the Greek financial crisis. And since the approach requires a hell of an investment, perhaps the medium, the state, the Ministry of Health and the public payers would be very skeptical of adopting such a policy. Okay. The other thing to consider is to increase the general public awareness over pharmacogenomics. So people should know why pharmacogenomics is important and how to exploit this to their own benefit. So this is part of the genomic literacy, as we call it. And at the same time, we should also try to ensure that healthcare professionals are adequately educated. And we wish to see whether there are any discrepancies among the educational environment in Southeastern Europe, because most of the times in Western Europe, things are more homogeneous. So we screened 98 universities in 175 countries in Southeast Europe. And what you see is that in very few countries like Greece, Italy, and Turkey, there were standalone courses of pharmacogenomics in the undergraduate curricula. And in the majority of cases in countries, you had only alluding to pharmacogenomics, only discussing pharmacogenomics in specific courses related to the discipline, which is genetics. And you see, unfortunately, countries like Cyprus or Malta that fail to discuss anything about pharmacogenomics. And the situation only gets worse if you look at the postgraduate curriculum. And this clearly shows that we need to come up with some kind of a harmonization between different educational curricula in South European countries. Of course, this is a study that has been done 10 years ago, so I would assume that things would look a bit better. But having performed the same study in Greece a month ago, unfortunately, you have similar degrees of discrepancy in those different countries and those different universities within the same country. And to try to alleviate this bottleneck, we have come up with a concept which is called the Golden Helix Conferences. The Golden Helix Conferences are educational events and research meetings that are organized by the Golden Helix Foundation, which is also the regional center of the Golden Helix Foundation in Southeast Asia, based on the partnership we have with VIN Big Data Foundation. And Golden Helix, just in case you're not aware of, stems from the house of Francis Crick in Cambridge. And as you can see here, you have a gold helix at above the main entrance of the house. So that's where Golden Helix was inspired from, to depict the relationship with genomic medicine, especially since the foundation was established in 2003, right after the completion of the first version of the human genome. And that's a very old slide. As you can see here, that's until 2016. But I can tell you now that until today, there have been 54 conferences organized in 44 cities in 26 countries around the world, mostly in Europe, but also in Southeast Asia, Africa, Latin America, and the US. And of course, Asia, including Singapore, Kuala Lumpur, and the like. And speaking of summer schools, of course, in Vietnam, you have summer 12 months every year. But to be able to enjoy the warmth of the Greek summer, every 2 years there is a summer school that's organized in Syros. You can see this location here by the sea, where we have a very stimulating scientific program and a very relaxing social activities. So you're all free to join, especially the invitation goes to the people that they're sitting with me in the room. And it's really something that the experience is really memorable. And for those of you that wish to enrich your knowledge about genomic medicine, there is an e-learning platform with modules related to genomic medicine, which is public health genomics, informatics, economics, and pharmacogenomics that lead to certificates and diploma, especially designed for people from developing countries. And my understanding is that soon this particular content will be also available in Vietnamese for medical professionals that they're interested in. So I'd like to finish by thanking the entities that have helped us in performing this type of research. And thank you also very much for your attention.
Thank you, Professor Dược. I think that's interesting. Something we are trying here in conflict either for the young generation and for the who are innovative in pharmacogenomics and in general, personalized medicine, and focus on kind of conflict with the audiences, especially the young generation. So some of the room is very young researcher in bioinformatics researcher, so that we can learn from some in here, and maybe the online audiences can do some questions as well. Maybe you can get some questions from online first, offline first.
There's a question here.
I don't know. It's just I had a.
Okay. Yeah. That's kind of a short lecture, kind of online lecture as well. But I think those lectures can be public. Please, yeah.
So do you think that the pharmacogenomics will be the future of the public health, or it is a smaller branch into the health? Yeah.
So basically, pharmacogenomics is a main achievement in it's considered to be the low-hanging fruit in the tree of personalized medicine, which means that is easiest to be reached. Okay, so it's not high, so it's not difficult to reach. It's very easy to reach. But to implement, you need to have some public health initiatives. So that's why those initiatives, the ones that I've described to you and that correspond to the temple, as the example I've showed you, that's a way to move forward and to expedite the implementation of pharmacogenomics in mainstream healthcare. So by addressing those needs, then you expedite the adoption of pharmacogenomics for mainstream clinical practice.
Yeah, thank you.
Mm-hmm. Mm-hmm. Yes. Mm-hmm. Yes. Yes. Mm-hmm. Yeah. So it's basically, as we said this morning, you should not wait until you get everything deciphered, because it will never be everything. You will always have uncertainties. Even if you manage to understand the whole genome, because we have to keep in mind that we have decoded it, we haven't understood it yet. So we should use the information we have at hand and explain the amount of information we already know. So we have 20,000 genes. We may be able to know what 2,000 or 3,000 are actually doing in our genome. So, but the rest of the information, it's with us. So in 5 years, perhaps the 3,000 genes will become 4,000. So the information is going to be more advanced. And that's why we should keep the genetic information with us, so we could address the same questions again and again as soon as the new information becomes available. So that's what I think is quite important. So we should get the information, our genetic information, available for us. And every year we could look back at the literature and try to find new correlations, or even correlations that have been withdrawn from the system, right? So that is the importance of having this. But we shouldn't wait until you reach 20,000 genes. This will never happen.
Online question. One of the question: what should we do for our patients? We could not just immediately when the genetic testing result is available, right? Or maybe exactly the question.
So the patients do not respond immediately, you said?
The question is, what should we do for our patients, not people? Yeah, the question explained, we could not adjust immediately when the pharmacogenomics is available.
So that's why you should get the pharmacogenomics result available. And what you should do is you have to decide what is your favorite gene pair, drug gene pair. What is the most prevalent situation you have in Vietnam? I hear that DPYD is very low, has very low prevalence. So it's pointless of looking at DPYD, but you may want to look at UGT1A1 related to irinotecan. So this is something you should definitely try to address when this information is needed.
So related to the rare or common values, the second question. The cost-effective aspects of PGI is one of the most concerning issues, and it depends on a lot on the frequency of the harmful variants. So the question is, which response of the allele frequency do you think makes sense in the test?
Yes. This is a very good question. And for that, you have the economists that they do the analysis. I cannot tell you if it is going to be 10%, 5%, or 50%. Okay. I know that we have run a study in Slovenia, and we have seen that I think a percentage of 15% of the population would make sense. But that's Serbia. Okay. Each country have their own values, frequency values. So this has to be independently calculated to come up with this type of question. But then again, when we mean cost effective, it doesn't really need to mean cheaper, because cost effective means that it could be also more expensive, but it would improve the quality of life of the patient. So for argument's sake, MRI is cost effective, but is more expensive than an X-ray. What MRI has better is the resolution. So you can get a tumor with MRI, but you cannot get it with an X-ray. So that is what will save a patient's life. And that's why it's considered to be cost effective, even if it is more expensive than the conventional intervention. So that's what we should have in mind. Even pharmacogenomic test can lead to the reduction of the side effects. Even if it is more expensive, it is still cost effective. But as I explained yesterday in a separate lecture, there are examples of pharmacogenomics that are both cheaper and better. So in this case, they should definitely get reimbursed by the national payers. I think there is some colleague that raised his hand or her hand.
Yeah. So I think people focus more on the issue.
Yeah.
Yes, so I think a lot of questions this morning and even now. So we have a lot of concern about how practical it is, what's the benefit for patient, can they afford the price, and can they afford something? So I think those very important questions. And I think one of the things that people now, especially the young doctors, in Vietnam, many young doctors, they are more interested in applying some advanced technology to their medical practice. But for young doctor and for young generation, maybe it's less opportunity for them to join the network, to get the knowledge and to get information from the leader in the field like you or some other. So how to expand the question? How to expand the knowledge to the young people, young physician, young student, and young scholar? What is efficient way to expand the knowledge to those generations?
So this is a very nice question. So we should basically try to focus on two different layers. The first layer is the healthcare professionals. And by healthcare professionals, I mean clinicians or biomedical scientists. Okay? So to do so, you can clearly focus on getting courses, online courses like the one I showed you. And as I probably heard when I mentioned that the plan is to launch similar courses jointly with the Think Big Data in Vietnamese to be able to provide a resource for clinicians to enrich their knowledge on pharmacogenomics. At the same time, you should move as early as high school to be able to enrich the genomic awareness of high school students, because eventually those will be the next generation of the population. And to do so, we have established in Greece an approach that is called BioSTEM. It's a STEM approach that aims to enrich the high school students, elementary school students' knowledge on pharmacogenomics and genetics in general. So this is what we're trying now to achieve. We have already expanded this to 5 different countries, and we really hope, jointly again with the Big Data and Gene Story, to travel to Vietnam and try to organize similar sessions of BioSTEM in private and public schools in the country. So by having those 2 approaches, it is likely to ensure that the level of genomic awareness and genomic knowledge gets increased in the country, especially for a developing country like Vietnam.
So apart from having STEM activities, this knowledge has to be taught in a very simple manner. And this can only be achieved with STEM activities. So I believe that this is the only way that you can start getting high school students involved in this type of effort. So this is what I believe would be the case, the solution forward. Okay, I see there are 2 questions in the from the audience. So one question would be, in some countries such as Canada, US, physicians tend to avoid prescribing those, yes. In principle, what I can say is that people from Asian descent should not be restricted from these treatments, but before getting this treatment, they should get tested for pharmacogenomics. So yes, they need treatment, and yes, they need to be genetically tested before they get a prescription. And perhaps in Canada, the US, they don't do this test, but in Europe, especially Britain, that it's full with people from India, from Pakistan, from Indonesia, from India, they do the test, and they're actually obliged to do the test. And that's according to the EMA regulations, that people should be able to do the test. And because they have the right to be prescribed with the best treatment option. There's also a second question. How could you tailor the report to patients and consumers who makes it accessible and avoid misinterpretation? So the only way to ensure proper interpretation of the result is to be communicated with the qualified genetic counselor. So direct to consumer is great, provided that the report is properly explained. If the report is not properly explained, this can cause more harm than good. So if there is a patient that got his result from a direct-to-consumer test, then he or she should be encouraged to seek proper guidance from a qualified genetic counselor. And ideally, the cost to do so should be included in the test that he has undertaken. And that's the only way that misinterpretation is avoided, especially in the case of pharmacogenomics, that you don't deal with mutations or variants, but you deal with haplotypes. And haplotype is much more complicated to address.
Thank you. So yes, I think the first section.
Okay, so we'll be back in 15 minutes. So have a coffee or sake, and then we'll see you soon.